Good afternoon, everybody. This is Dr. Dasaga. This session is entirely devoted to the medical management of heart failure with reduced ejection fraction. And without much ado, can I request Dr. Ponde, cardiologist from Mumbai, to speak on about the role of ARNI in the management of heart failure with reduced ejection fraction. Dr. Ponde.
Thank you, sir. My job here is to talk about the real-life cases of ARNI. Can you see my slides, please? Can you hear me well?
Yes. Yes, I can.
Can you see the slides?
Very well. Yeah, I can see the slides very well.
Thank you. So I'm going to put some real-life cases of ARNI use in the in real world. First is, this is a common question asked: how do you manage HFrEF patients with a low BP? Now I will show you a case where 62-year-old patient of mine, 65 kgs in weight, non-diabetic. He had hypertension for 12 years, no asthma or COPD. He was admitted with acute pulmonary edema 6 months ago, and coronary angiogram was normal in that admission. Now he came to my clinic with a pulse of 74, blood pressure of 105/70. He had no RALs, no edema, but he was still NYHA class 3 symptoms. He was getting breathless even on taking a bath or even doing some modest domestic activities. And he also had some dizziness for the last 2 weeks. His medications were Ramipril 5 mg twice a day, amlodipine 2.5 once a day, Aldactone 12.5 mg once a day, Carvedilol 6.25 twice a day, and Torsemide 20 mg once a day. His ECG clearly showed left atrial enlargement, left ventricular hypertrophy, and strain pattern. The chest X-ray showed clearly left ventricular hypertrophy, pulmonary conus, pulmonary arterial enlargement, and even right atrial enlargement. What steps did I take? We should check the volume status in this. There was a postural drop of more than 20 millimeters of mercury here. The skin turgor was little less, and I wanted to see IVC diameter and collapsibility. Then we should stop all the medications that reduce blood pressure but don't benefit a heart failure with reduced ejection fraction patient. There is a lot of background noise. Can the audiovisual team look at that, please? Down titrate the dose of loop diuretics or stop them altogether, and reduce the dose of ACE inhibitors if necessary. And think whether we can change any other medication. Now look at here, the ejection fraction was 25% and IVC was completely collapsing. It was less than 5 millimeters in diameter and completely collapsing. So obviously the patient was hypovolemic. I checked his postural drop, it was 20 millimeters of mercury, yet the E by E prime, which is a surrogate of pulmonary capillary wedge pressure, was sitting at 28. So first thing I did was I stopped amlodipine. Second thing, I stopped torsemide. A week later, the systolic blood pressure increased to 120 millimeters of mercury. The postural drop reduced to 6 millimeters of mercury, but he was still in NYHA class 3. So this was a strong indication that I need to shift him to ARNI. We all know about conventional sequencing and proposed new sequencing. I could have gone to new sequencing starting dapagliflozin, but here I knew that the E by E prime was elevated. And in this patient, the first thing to get it down was to get down the E by E prime, get down the NT-proBNP, and there's no other better drug than ARNI to do that. So I just followed the ACC 2021 protocol, starting ARNI for this patient as an upfront therapy after stopping Ramipril. So I stopped Ramipril for 48 hours, started ARNI 50 mg twice a day. 2 weeks later, mind you, there is a lot of background noise. The audio-visual people, please stop the background noise. Yeah. No, it is still there very much.
Monica, please stop the background.
Tremendous background noise.
Where it is coming?
So
yes,
that's fine.
Now it is stopped.
So systolic blood pressure was 110 millimeters of mercury. The heart rate was 76, but he felt better. And IVC now became 14 millimeter with 50% collapse. And the E by E prime reduced to around 18 from 28. Now the next question was, so I have stopped amlodipine, I have stopped Ramipril, I have stopped the loop diuretics. Now he has become euvolemic. Systolic blood pressure is better with 50 milligram BD of ARNI. How do I titrate the dose? Can I go ahead with 110 millimeters of mercury? So what I did was, I was talking to John Cleland in the last CSI Bombay meeting, and he said, first thing that you can do, a trick of the trade you can do, is stop Carvedilol. Because Carvedilol is an alpha and a beta blocker and reduces blood pressure a little more than bisoprolol. So I stopped Carvedilol and introduced bisoprolol, 2.5 milligram once a day, and increase ARNI to 100 milligram BD slowly over the next 6 weeks. Systolic blood pressure stayed at 110. Heart rate 70 with bisoprolol. One must know that bisoprolol causes much better decrement in heart rate as compared to carvedilol. NYHA class 2 now. So he came from NYHA, returned from NYHA class 3 to NYHA class 2. And look at now, this is the pre-ARNI and this is the post-ARNI. The contractility of the apical segment, what the apical segments, looks much, much better. This is the apical two-chamber view. Look at the apical segments here. The apical contractility, apical septum in particular, looks much, much better, and ejection fraction increased to 31%. This is over 6 weeks of ARNI therapy. What is even more impressive is the E velocity, which was sitting at 115 centimeters per second, reduced to 77. And E equal to A, here the E was much, much A. So this was a restrictive filling pattern, increased to non-restrictive filling pattern. The E and A are almost equal. At times the A is even becoming more than E. So E by E prime baseline was 18, which was reduced to 28, which was reduced to 18 after ARNI. And this reverse remodeling response to sacubital valsartan therapy is the absolutely impressive thing to see in clinical practice. This is what makes the patient feel better. This is what makes them return from NYHA class 3 to class 2, not the improvement in ejection fraction. It is the improvement in the diastolic properties of the ventricle, which is very important. So in this study also, out of 25 patients with HFrEF, optimally treated with ARNI, switching from other RAS blockers to ARNI, followed for around 4 months. The percent of patients with restrictive filling pattern decreased from 47% to 23%. And in my patient, the pulmonary artery systolic pressure by TR jet, his IVC was very small at the beginning. You remember, he was hypovolemic. So 65 plus 5 was around 70 millimeters of mercury. And after ARNI, the pulmonary artery systolic pressure in around 6 weeks returned to 35 millimeters of mercury. So this is what we can do with ARNI, even with patients with borderline systolic BP. The crucial steps are, number 1, stop their loop diuretics. Number 2, if they are on carvedilol, shift them to bisoprolol. Number 3, if they are on any other antihypertensive drugs which do not benefit HFrEF, stop them. Stop them, particularly nitrates. If they have no angina, stop nitrates. If they are on amlodipine, stop amlodipine. And then you will get the margin to introduce ARNI a week or 2 later. And then slowly build up the dose to 100 milligram BID. And that is the dose which usually gives impressive improvement in ejection fraction and diastolic properties. Now, this is a new second patient. Is a new therapy of ARNI beneficial? ARNI reduces the risk of cardiovascular death and hospitalization in patients with low systolic BP as well. It also causes 15% reduction in all-cause mortality. This is the paradigm HF data. So, ARNI improves natriuretic peptide, nitric oxide, prostaglandins, and bradykinin, producing vasodilatation, diuresis, and anti-fibrotic and anti-hypertrophic properties of the ventricle. So, it's very important to remember, even in low systolic BP, you can use ARNI. And the number of patients permanently discontinued because of hypertension were quite small in paradigm HF trial, 1% patients. Now, there's a second patient, ischemic dilated cardiomyopathy, posted for an ICD implant. This is a 79-year-old male, 67 kgs in weight. He had diabetes and hypertension for 20 years, mild COPD, paroxysmal AF. He had previous ASMI 18 years ago on CABG in 2009. He presented with HFrEF. Creat was 1.5, potassium was 5. When I saw him first, he was on ramipril, bisoprolol, aspirin, rosuvastatin, metformin and basal insulin, and furosemide. His ECG showed atypical intraventricular conduction disturbance, little broad QRS, neither fitting into LBBB nor fitting into RBBB. There were multiple atrial ectopics as well. And if you look at the ventricle, the ejection fraction was close to around 30%. The E was much more than A, E prime was reduced, and the E by E prime was 22. What I did was, again, I reduced his loop diuretics to half, shifted from ramipril to ARNI. Initial dose was 50, and then up titrated to 100 milligram BID in 8 weeks. Unfortunately, I couldn't introduce MRA because potassium stayed 5.1 despite low potassium diet. And what I did was, he was a diabetic, remember, on metformin and basal insulin. I start dapagliflozin from week 4 onwards. And look at the ventricle. The ventricle looks much better now. Ejection fraction 38% at the end of 12 weeks. This was with ARNI and dapagliflozin together by 12 weeks. The ejection fraction, overall contractility looks much better. And the E by E prime now comes down to 12. Pulmonary venous flow normal. So in paradigm HF also, 80% of total deaths were cardiovascular deaths. And out of those deaths, half of them were sudden deaths. There was 22% risk reduction in sudden deaths observed with ARNI versus enalapril in paradigm HF trial. Notably, this incremental reduction in sudden deaths was also observed in patients receiving optimal dose of beta blockers and MRA. Both of these therapies are proven therapies to reduce sudden cardiac death. Despite them on board, ARNI gave incremental reduction in the reduction of sudden cardiac deaths. So the effect of ARNI versus on ventricular arrhythmias in patients who have ICD is very notable. In this one study, 120 patients with ICD, yes, I know, with ICD, with NYHA class more than 2, and ejection fraction less than 40, ventricular arrhythmias and inappropriate shocks were much less in patients who are on ARNI. So the guidelines also say an ICD is recommended to reduce sudden death only after trying optimal medical therapy for 3 months and ejection fraction remains less than 35%. So will introduction of ARNI reduce the need for device therapy? Certainly. And this one paper has shown that if you give 6 months of optimal medical therapy, you can reduce the number of ICD implants because the ejection fraction goes beyond the cutoff limit. It improves above the cutoff limit of 35% in 6 months. So initially the guidelines said 3 months of therapy. Now the guidelines have extended the waiting period to 6 months. So you must take at least 6 months of optimal therapy with ARNI, beta blockers, MRA, and dapagliflozin to wait for the ejection fraction to be recalculated to decide the need for therapy. Thank you very much for these 2 cases. Thank you very much.